Hello, everyone. Thank you for your patience this evening. We can just go ahead and get started, actually, since we're a little bit behind 5:30. So thank you all for joining us this evening as we celebrate National Lung Cancer Awareness Month. The ALA, with dedicated health professionals and institutions, are happy to bring you an educational webinar focusing on new advances in lung cancer screening, diagnosis, and treatment. This educational webinar and the work of the American Lung Association would not be possible without the incredible support of tonight's sponsors. Thank you to University of Chicago Medicine, Intuitive, and City of Hope for supporting our mission. Before we get started, you may have noticed your microphones and cameras have been disabled for tonight. We encourage you all to engage with us through the Teams chat box. You should be able to see it at the top right of your screen. And if you are willing, please share with us your connection to lung disease and feel free to introduce yourself. We will answer as many questions as time allows at the end of tonight's webinar. If you have any questions for the speakers, please post them in the Teams chat box. Now we'll get started with a presentation from Michaela Pittman, National Manager of Health Promotions at the ALA, who will share information on our 2023 State of Lung Cancer Report, current lung cancer initiatives, and resources available at the American Lung Association. Welcome, Michaela.
Thank you so much for inviting me tonight to speak on the Lung Association's behalf. And thank you for that introduction. You can go to the next slide. Perfect. So you will find some links and QR codes throughout the presentation. Feel free to use them at your leisure before or after this call ends. So next slide, please. So the American Lung Association was founded in 1904 by a group of volunteers dedicated to ending the lung health threat at the time, tuberculosis. The Lung Association and partners prompted the first Surgeon General's report and have helped over 1 million people quit. We are a major backer of smoke-free air laws, and we work to improve tobacco cessation coverage nationwide. With TB largely controlled in the US, we have since extended that mission to other respiratory diseases, such as asthma, lung cancer, and COPD. Next slide. For more than 119 years, Americans have trusted us to protect their lungs, whether it's researching treatments and cures for lung diseases, keeping kids off tobacco, including e-cigarettes, or advocating for laws that protect the air we all breathe. Our vision is a world free of lung disease, so with this, our goals are big. Defeat lung cancer, champion clean air for all, improve the quality of life for those living with lung disease, and create a tobacco-free future. Each imperative is constructed with the idea that achieving health equity must be the foundation of any lung association goal, objective, or strategy, because when you can't breathe, nothing else matters. So I'd like to first discuss the 2023 State of Lung Cancer Report for Illinois. First, in March 2021, the United States Preventative Services Task Force expanded its recommendation for screening. This dramatically increased the number of women and Black individuals who are considered at high risk for lung cancer. Unfortunately, in 2021, only 5.8% of those individuals were screened. Based on the new guidelines, our report defines those at high risk for lung cancer as those who are 50 to 80 years of age, who have a 20-pack year history, and currently smoke or quit smoking within the last 15 years. At this time, there's not enough evidence to show that screening is recommended for other groups. However, we do encourage individuals to talk with their doctor about any concerns or questions that they may have. Next slide. Now on to the data from the 2023 State of Lung Cancer Report for Illinois. The rate of new lung cancer cases in Illinois is 59.7 per 100,000 people, which is significantly higher than the national rate of 54.6, but still puts us in the average tier. Over the last 5 years, the rate of new cases improved by 17%. Illinois is ranked 18th for rate of surgery, with 21% of people with lung cancer undergoing surgery as part of the first course of treatment, which is similar to the national rate. Patients who are not healthy enough to undergo a surgical procedure or whose cancer has spread too far may not be candidates for surgery. Just 5.6% of those at high risk for lung cancer were screened, which is still higher than the national rate of nearly 5%. For comparison, however, the breast cancer screening rate for women over 40 is 50%. One of the racial disparities highlighted in the report is that 19.7% of lung cancer cases are diagnosed at an early stage among Asian Americans or specific islanders in Illinois, compared to 28.4% of white people in Illinois. Additionally, the rate of new lung cancer cases for Black individuals is 68.2 per 100,000 people, which is significantly higher than the rate of 63.9 among white individuals in Illinois. Next slide, please. Finally, the percent of people alive 5 years after being diagnosed with lung cancer in Illinois is 27.2%, which is higher than the national rate of 26.6%. And over the last 5 years, the survival rate in Illinois improved by 14%. For patients receiving treatment, Illinois ranked 15, with 17% of cases not receiving any treatment, which is significantly lower than the national rate of 20.6. And 27.3% of cases are caught at an early stage, which is significantly higher than the national rate of 26.6%. Illinois was one of the 46 states whose Medicaid fee-for-service programs covered lung cancer screening as of this summer. However, Illinois Medicaid did not follow the recommended guidelines for determining eligibility. As you can see, Illinois has several areas for improvement when it comes to lung cancer outcomes. However, significant progress has been made in recent years, and you can see additional data and how other states compare at lung.org/SOLC. Next slide. So what is the American Lung Association doing about the lung cancer burden in Illinois? So we are doing a lot. Through the Illinois Lung Cancer Screening Initiative, the Lung Association is supporting and promoting comprehensive lung cancer screening programs and increasing lung cancer screening rates among white and Black men and Black women. This initiative works to integrate public health equity best practices through building awareness and reducing barriers to care, increasing early stage cancer diagnosis, and reducing morbidity and mortality rates across the state of Illinois. Next slide. Designed specifically for the Illinois Lung Cancer Screening Initiative, our first resource, the Lung Cancer Helpline, provides client support to health system patients and community members who exhibit barriers to lung cancer screenings, including providing assistance in determining screening eligibility, scheduling, and locating a screening center, as well as offering transportation assistance, screening coverage for those who are uninsured, underinsured, or have a high deductible, and free tobacco cessation referrals to the Illinois Tobacco Quit Line. Illinois residents can call the Lung Cancer Helpline Monday through Friday, 9 a.m. to 5 p.m. Central Time at 844-ALA-LUNG. Next slide. This initiative also has a variety of resources that have been developed to share and educate patients, providers, and community members about the resources available through the Lung Cancer Helpline. These materials include a lung.org landing page highlighting this project and the importance of lung cancer screenings, as well as English and Spanish promotional materials, including a postcard, a rack card, and a poster. All of these are available for free shipping to individuals, health systems, and organizations, and we highly encourage the sharing of the materials to those who may be high risk during appointments, in lobbies, at events, and even through newsletters and listservs to providers and community members. You can order materials through our website at lung.org/LCS-initiative or through the QR code on your screen. Next slide. Tobacco use is the single most preventative cause of disease, disability, and death in the U.S., and cessation services and resources are more important than ever. The Lung Association has expertise on a health system's change to increase tobacco cessation, and we can provide guidance on electronic health record implementation, quality measures, hospital community benefit requirements, and how emerging issues will impact tobacco cessation in health systems. You can access resources for these issues and more on our website at lung.org/cessation-TA. And second, since it was first introduced over 41 years ago, the American Lung Association's Gold Standard Freedom from Smoking program has helped hundreds of thousands of individuals end their addiction to nicotine and begin new smoke-free lives. Based on proven addiction and behavior change models, The program offers a structured, systematic approach to quitting, and its positive messaging emphasizes the benefits of better health. Led by a certified facilitator, Freedom from Smoking is the only cessation program made available nationwide through multiple delivery methods. To learn more about freedom from smoking and how to become a facilitator, visit lung.org/FFS. Next slide. On the screen here, you'll see a list of additional resources. So at savebythescan.org, individuals can learn more about lung cancer screening and take a short quiz that determine one's screening eligibility and if they should talk to their doctor about being screened for lung cancer. In this past fiscal year, we reached a milestone of 1 million people having taken our Save by the Scan quiz, and over a quarter of them were found to be at high risk. Individuals can also visit lung.org/USPSTF-toolkit, where you can find information about coverage, billing, and other recommendations. You can also visit the American College of Radiology Lung Cancer Screening Locator tool, which can help individuals find a lung cancer screening program near them. Health systems are also encouraged to reach out to the ACR regarding registering a lung cancer screening facility as well. You can learn more about lung cancer basics and how to support a loved one or a patient and how to get involved at lung.org/lung-cancer. And you can view our interactive online courses like how to help people quit, tobacco basics, and additional cessation modules at lung.training. You can also take it a step further through the final 3 links by viewing our Addressing the Stigma of Lung Cancer Toolkit, our Addressing Tobacco Use in Communities Health Equity Toolkits, and searching for available clinical trials. And of course, I can't forget the link to the Illinois Tobacco Quit line, quityes.org. Next slide, thank you. So I shared a lot of resources today. However, the 2023 State of Lung Cancer Report highlights that Illinois must do more to reduce the burden of lung cancer and encourages everyone to help end lung cancer. Join the American Lung Association's efforts by asking your member of Congress to co-sponsor Bill 4286, the Increasing Access to Lung Cancer Screening Act. The bill provides for coverage without prior authorization requirements of annual lung cancer screenings under Medicaid, Medicare, and private health insurance for individuals for whom screenings are recommended under USPSTF guidelines. It also expands Medicaid coverage of counseling and pharmacotherapy for cessation of tobacco use to all individuals rather than only pregnant women. You can contact your member of Congress about this bill at lung.org/action or by scanning this QR code on the screen. So thank you again. Now I would like to pass it over to Dr. Desai, who will be focusing on lung cancer screening and lung nodule management, biomarkers to robotic assisted bronchoscopy. Welcome, Dr. Desai.
Thank you, Michaela. I think that was fantastic. And I think so impressed with the work that American Lung Association does. And with the state of lung cancer report that comes out, I'm eagerly waiting every year to see where we are. And I can tell you that, when I started my pulmonary fellowship, I think one of the theme during our fellowship was once you're diagnosed with lung cancer, the survival is very poor, right? I think, many of us have lived that, where the survival was 17%, 15%. It's exciting to see where we are right now. And a lot of us, I think, in this webinar, we're going to talk about, the nuances and the updates and the exciting thing that we are doing to improve lung cancer survival. And there's a lot of hope and positivity as well. So we can advance the slide, Olivia. These are my disclosures. I'm going to talk about, one of the technologies that I've included in my presentation. That's intuitive ion. And I do, I'm a consultant and also part of a couple of research projects for them. Next slide. So, I've broken down, my presentation into different aspects. I know Michaela covered, a lot of on the lung cancer screening. I'm going to talk about the why, and the who, right? I'm going to talk about, once someone undergoes lung cancer screening or they are found to have lung nodule, what are the types of lung nodule? How does a doctor or a provider, when you are seeing them, evaluate or think about the lung nodule, what makes them think about, the risk, why are certain nodules more riskier than others? And then we'll talk about some of those evolving concepts of lungs, risk stratification, biomarkers that are involved to check for risk for lung nodule, and also minimally invasive tools to biopsy, endobronchial ultrasound. We'll talk about robotic bronchoscopy, and I'll talk a little bit about our nodule program as well. Next slide. So, the reality is that lung cancer is still the #1 cause of cancer-related deaths. It is, it is #2 in terms of number of cancers, but it's still the #1 cause of cancer-related death. Next slide. So, in the state of lung cancer report, there are a lot of positive things that came about, in that state of lung cancer report for Illinois. We actually are significantly higher nationally compared to the overall survival. So if someone has to have lung cancer in state of Illinois, their survival is higher than the national average. That said, we are not the top, in Rhode Island and is #1. We are 20th, in that, not bad, but still a lot of work to do. Over the last 5 years, we have seen early diagnosis rate in Illinois not change much. And partly, I think Michaela touched on that, is that lung cancer screening numbers are still low. So we have a lot of work to be done. What we know from the state of lung cancer report is that, when diagnosed earlier, right, when you look at the 63%, if you're diagnosed, if you look at on the left-hand side, the dark blue, that is the early diagnosis, the survival is the highest when lung cancer is diagnosed early. So we want to make sure that we diagnose lung cancer early. Next slide. So why does it matter? Because if you think about it, and we can advance it a little further, Olivia. So it matters because at the earliest of the stages, right, we're talking about stage 1A lung cancer, the survival can be as high as 92%, which is very similar to what survival is for breast cancer. If someone has breast cancer, the survival is approximately 90%, over 90% in 5 years. So that should be our goal. So how do we do that, right? So we do that by lung cancer screening, and we do that by getting a low dose CT, which is a very simple test which patients undergo in 25 seconds, very minimal radiation. That is really the best way to screen cancers, lung cancer. We have looked at, chest x-ray, sputum cytology. CT scan is the best way to screen for lung cancer. Next slide. And this was actually, this came about by a landmark trial that was published in 2011 in New England Journal of Medicine. They looked at a really, really large number of patients, 54,000 patients. And I don't think we can ever replicate a screening trial as big as this. What they found when patients underwent low-dose CT, that is low-dose CT, which we talked about, the screening modality, for annually for 3 years in this study, they found that they actually could save lives. And there was a 20% risk reduction in deaths compared to chest x-ray. And when they found that these patients were also at risk for developing other problems, they found other things as well. So all-cause mortality was even further, there was more impact to that. So number needed to screen was 219 to prevent 1 death in all-cause mortality. So very impactful study. It proved that lung cancer screening saves lives. Next line. And so when I talk about lung cancer screening is so important, why do I say that? Because when you compare breast cancer, and mammogram, and we compare colon cancer and colonoscopy, it takes about 600 colonoscopies, 668 colonoscopies to save 1 colon cancer related death. When you look at low dose CT, it takes only 320, and impact is even more when you look at all cause mortality, and still it's underutilized. So it's a very impactful test to prevent cancer-related deaths. So, certainly it's proven that it is a very good tool. Next slide. So, obviously, in 2011, the initial, trial, the NLST trial came about. U.S. Preventative Services Task Force updated the guidelines in 2013, or actually came up with the guidelines in 2013, and they updated more recently with more recent data that pointed that we need to include more patients in here and expand. And then subsequently, NCCN updated their guidelines, and more recently, American Cancer Society updated their guidelines. Really, the theme is that we can benefit more patients. So the guidelines expanded to 50 to 80. So if someone is 50 to 80 years of age and who has smoked cigarettes, more than 20 pack years smoking, in recent update by American Cancer Society, they took the limitation in terms of how many years since quitting, but that's usually something that we follow right now. CMS is still using that one should have quit less than 15 years or is a current smoker. And one of the other important facts is that someone needs to be asymptomatic. We see benefit from lung cancer screening, when it's done annually. So if someone gets a CT scan, there's a lot of benefit in doing annually, either till they turn 80 or if they have quit more than 15 years as of now. Next slide. So, obviously, with screening, there's some potential harms, and one of them we have realized and we recognize that there's a lot of false positives. That means not everything that's detected on lung cancer screening CT is going to be cancerous, and obviously that leads to anxiety and also some diagnostic challenges for clinicians to get to the bottom of why those problems are. So what we call as incidental findings are detected. Now, these can be considered to be actually not a harm, but a positive. But, patient distress, radiation exposure, and oftentimes, there can be something called as overdiagnosis bias as well. Next slide. So, really, there are two ways I see, us eliminating lung cancer or that are preventable causes of lung cancer. There, one is cigarette smoking, and we all know the huge impact, and that is really one of the key ways to eliminate lung cancer. And a lot of work has been done, and we have started seeing the decline in lung cancer, in part because of the efforts by ALA and all the organizations around that as well. The other, often overlooked, but a preventable cause is radon exposure. And in Midwest and Illinois, there's a lot of radon exposure, and ALA also has been in the forefront in educating communities around that as well. So, I would say that it's ALA radon is a naturally occurring gas, often found in areas where there is a lot of uranium that gets turned into radium, and eventually a radon gas is emitted. If anyone has not checked and they have a basement, I would strongly recommend checking for radon. And there's a lot of mitigation factors that can play a part, and so you can actually reduce the risk of lung cancer by that as well. Next slide. So, obviously we talked about lung cancer screening and how to prevent lung cancer. Now, concept of lung nodule, right? So when someone gets a CT scan and they are found to have an abnormality, oftentimes clinician might say, or provider might say, that you have a spot in the lung, a shadow. And oftentimes what they mean is really they have a lung nodule, right? And it is, it is a round area that's more dense than the normal lung tissue. And usually it's less than 30 millimeters in size. So anything more than 30 millimeters, oftentimes we refer to that as lung mass. So very important to understand the terminology, because anything over 30 millimeters is considered lung mass, and that increases the risk of it being cancerous. Next slide. So these are some of the examples of lung nodule, and to the left upper hand corner is what we call as a ground glass opacity, which is GGO. Oftentimes we refer to that. To the top right hand corner is a part solid, part GGO, and the bottom is a solid type of a lung nodule. Many believe that lung cancer starts in its earliest phases from the left and progresses to the right and goes down, becomes more solid as well. So the risk factors also change. The one in the bottom, the one that is solid, has the highest risk of lung. It's the highest risk of lung cancer. Also, part solid and part ground glass, whereas ground glass opacity has the lowest risk of being lung cancer. Next slide. So, but not all lung cancers that we see are, not all lung nodules are going to be cancerous. There are different reasons why one can have lung nodules, can be cancerous, obviously, but there are different types of cancer, not only lung cancers, but also it can be non-malignant causes. And the list is very exhaustive. But, it's important to remember that not all lung nodules are going to be cancerous. Next slide. So, a couple of questions. If I had to mention that this is probably one of the most important slides for patients and caregivers, the questions to ask, when you are seeing a doctor or a provider, when you have been diagnosed with the lung nodule, ask about the size of the lung nodule. And we'll talk a little bit about why, what type of lung nodule do I have? What is the risk of this being cancer? Because we have tools that can actually help us predict that. Am I a good candidate for a blood test? So there are some blood tests, believe it or not, that can help us risk stratify. Do I need a biopsy? Do I have any lymph nodes that are involved? Does my doctor specialize in lung nodules? And it's not, an inappropriate question to ask if because you want to see someone who is specializing in these, in these diseases. And does my doctor or surgeon perform minimally invasive procedures? And as we are going to, as we go in the webinar, Dr. Madriaga is going to talk about many of these surgical techniques as well. Next slide. So size does matter, right? We know that from evidence and data is that the larger the spot in the lung, size, there is a very high chance of this being cancerous. Smaller nodules have a lower chance of being cancerous. And when you are looking at different sizes, 5 millimeter, when you look at it, it's tip of a pencil. A cereal is about 10 millimeters. A penny, 2 centimeters, and a golf ball is about 4 centimeters in size. Next slide. So, the way I look at it when I sit down with my patients, first when they come in with the, lung nodule, what I do is, I look at the guidelines first, right? I look at different guidelines that help us, risk stratify and help us how to manage our patients with lung cancer. So there are different guidelines, Fleischner, lung rats, ACCP. And then what I do is, look at their age, how the nodules are, and I put them into prediction models, right? So we look at their different models. There's Brock University model, Mayo, Herder, VA models, and then we come up with what we call as a risk for cancer. And then I see if my patients are good candidates for any blood tests, and we'll talk a little bit about where they are helpful. And then we talk about, should we consider doing a biopsy? Should we just consider monitoring them by CT scan? Or should we consider sending them directly to Dr. Madriaga to get resection? So we, really are looking at those things as well. So next slide. So, I'm not going to go into the details, but these are some of the, societal guidelines that we are looking at. They tell us when it's size different based on the size, what the, next step should be, we should be doing. Next slide. Similarly, as I mentioned, the different models that are there, essentially what we look at is someone's, age. We look at where the nodule is located, the appearance of the nodule. Oftentimes, we may do a PET scan to help with the risk stratification. It's very helpful because I think oftentimes, we when we put in and plug in all the data, to our surprise, it may change what we are perceiving. We may think that this is not as risky, or it may be risky, but then the model tells us differently. So very useful tool. All my fellows and our team always we put in data in that and come up with a risk stratification number. Next slide. Next slide. So we have done that, then what we do is then we come up with the risk. And so if someone has risk that is less than 5%, I don't think anyone should be doing more than a CT scan in a short interval. We should not be doing biopsies. We should not be doing any interventions for these patients, because these are the low risk patients. And I think getting CT scan is very appropriate for that group. More than 90%, or when they are very high risk, we should question whether we should be doing a biopsy or sending it directly for a surgical resection. It comes in, the question and the dilemma comes in when someone is intermediate or not in the high risk, not in the very lowest risk. That's when we should be looking at doing more, either biopsy, or even should we consider doing a PET scan to see what the risks is. Next slide. And that's when I often get asked by my patients, is there a blood test that can help me, sort of tell my risk whether this is cancer or not? No, we don't have a test that is going to tell us 100% if something is cancer or not. But we have some tests in someone who is, on the low to intermediate risk, we can do that can help us rule out lung cancer. And that's actually, our center was one of the centers for this study. And next slide, or we can advance it. And that actually helps us in low to intermediate risk patients to rule out malignancy with a very good sensitivity and a very good negative predictive value for this test. Next slide. So this is how it fits into my algorithm, or when I'm talking to my patients, is that when they're low to moderate risk, I'm going to go ahead and order this test, Notify Lung, which is a blood test to help us risk stratify. If it turns out that they become even more low risk, then I will continue following them with CT scans. If they become high risk, then we will consider doing a biopsy, or if they stay intermediate, then we will consider doing a biopsy or surgery, depending on what we find. Next slide. We're also part of another study which is looking at nasal swab to predict a similar issue, whether patients have lung cancer. We are studying this in patients who have low and moderate risk. So stay tuned. Hopefully within a year or so, we should be talking a little bit more about that. Next slide. Next slide, please. And we can advance it further. So one of the other things, as I mentioned, obviously we talked about, what the nodule size is. And we can go back one slide, Olivia. So, when we talk about nodule, the risk, and now we're talking about, what the next steps are. And if your clinician and your doctor feels that this is, a suspicious nodule, then we want to make sure that you also ask the question, are there any lymph nodes that are involved? And in that, lymph node staging is one of the most important aspects of lung nodule diagnosis and also lung nodule care. So in this, in 2023, we have different options to do a biopsy. It can range from invasiveness to diagnostic yield. What that means is that we have less invasive to more invasive tests. Now we have tests like, tools like robotic bronchoscopy that can actually help us not only diagnose, but also with minimal side effects as well, or complications. Next slide. So, there are many robotic tools. At our center, we have adapted ION, which is a robotic platform that helps us navigate and reach to the lung nodules. Next slide. So what is ion or robotic bronchoscopy? Essentially, if you look at paper maps, right? I mean, back in the day when we used paper maps to get from one place to the other, and then came about, GPS or navigation system in our cars that changed the way we go from one place to other. Similarly, bronchoscopy, we were using paper maps by just going with a plain bronchoscope, and robotic bronchoscopy is like our GPS of the lungs, which helps us get to the nodules, which were very hard to get to back in the day. Next slide. So, obviously, last year when I was talking about this, the data was, it was fairly new technology, and we didn't have that much robust data. And now we have a lot of data now coming out, for this technology. We know that, the diagnostic yield is very good. In studies it varies, but mean is about 90%, and the rates of complications are extremely low. So very safe procedure. Next slide. So, one of the things that I get asked about in our when I'm talking to patients is what about doing a needle biopsy? And then this study from Mayo actually addressed that. They compared actually both the ion or robotic bronchoscopy with CT guided needle biopsy. What they found was the rates of getting an answer was very similar between the two technologies. And the rates of complications were significantly higher with CT guided needle biopsy. One of the other important factors that they addressed was during the bronchoscopy, 81% of the times they were able to actually look at the lymph nodes and stage the mediastinum, which is a very important part that we talked about. Whereas in someone who had undergone CT guided needle biopsy, they had to actually undergo another procedure 37.2% of the time. So really, we're talking about duplicating efforts and which may not be needed. Next slide. So essentially, this is all what we know in our evidence. Robotic bronchoscopy is safe. You can actually target multiple biopsies, multiple nodules, and also do stage the hilum and the mediastinum during the same setting. Next slide. More really exciting tools like cryobiopsy are going to be helpful in getting more biopsy specimens as well, especially when Dr. Mohindra will talk about the molecular testing. We can actually get more samples to do those tests as well. Next slide. This is an example of a patient who had a right upper lobe nodule, as you can see, all the way up in the apex, and on the, very hard to get location, even with the CT guided needle biopsy. Next slide. So what we did was we proceeded with a robotic bronchoscopy, and we can start the video. So what we did was, we planned this patient's with the help of the CT scan, we planned how to get there. And you can see on the lower left-hand corner is a virtual image, and to the right lower corner is the real-time image. So during the procedure, I'm able to actually see both virtual and have real-time guidance. And the robotic bronchoscope can actually help us get there. Next slide. Much like in our GPS in our cars, when we actually get there, it tells you that you're there. Similarly, in this setting, we know that when you see the target, we know that we are there. In this setting, we can also advance tools like ultrasound to confirm. We also have the advantage to know how far we are away from the lesion, and also know how far we can go. So we know that we are in the lesion. So for example, here, it's about 10 and 26 millimeters. So I'm about 10 millimeters away from the lesion and 26 millimeters away from the far edge. So I deploy my needle to about, say, 15 millimeters. So I'm right in the nodule. Next slide. And this is what we found. We found adenocarcinoma. This is our experience. Our yields are very similar to what we have seen in the literature, and also very similar in terms of pneumothorax rates as well. Next slide. And what we really want to do, when we are managing patients with lung nodule, is develop a multidisciplinary approach where instead of having patients go through multiple doctors, make sure we are discussing in a multidisciplinary fashion. And that's true across all the lung nodule programs, like ours, where you come up with a plan and then get to the treatment as fast as you can. Next slide. And I think I'll tell you that taking care of lung cancer patients and being part of the lung cancer team, one of the most important members of the team and the backbone of a lung cancer team are lung navigators. And really these are the ones that help our patients. I cannot tell you enough that how important a role of lung navigators is in a lung cancer program. So thank you to all our lung navigators that help support our programs. Next slide. And so in conclusion, lung cancer screening is very important. These are the criteria: 50 to 80, 20-pack year smoking, should discuss with your clinicians. Lung nodule is complex and requires a multidisciplinary approach. There are a lot of models, a lot of technologies have evolved over the years, and really exciting to see those evolve and improve lung cancer mortality. And with that, I'm going to conclude my talk. But just the take-home message is lung cancer screening saves lives. Thank you. With that, I'm going to hand it over to Dr. Madriaga, and she's going to talk about minimally invasive thoracoscopic surgery for lung cancer, VATS to robotic surgery. She is assistant professor at University of Chicago Medicine. Thank you, Dr. Madriaga.
Thank you so much for that great introduction, Dr. Desai. Next slide. So don't need to belabor this point, but surgery mainly plays a role in early stage non-small cell lung cancer, which includes stage both 1 and 2, which is localized, and stage 3, locally advanced. And the proportion of patients with stage 1 to 3 disease is expected to increase as screening becomes more common. Next slide. So in this talk, I'm going to focus on how we advance care for patients with early stage non-small cell lung cancer, and in particular, how we can make surgery better tolerated for these patients. And the aspect that we'll focus on today is how we conduct minimally invasive surgery for patients with lung cancer. Next slide. So the history of what we call VATS lobectomy, video-assisted thoracoscopic surgery, starts in the 1900s when fluoroscopy was introduced, basically making a small incision in the chest and looking at the inside chest wall to see what was going on, particularly in patients with tuberculosis or other chest infectious diseases. In the 1990s, VATS was introduced with double lumen endotracheal tube, endoscopes, and surgical staplers. And initially, the VATS lobectomies, meaning taking out a lobe for cancer, used mass hilar ligation. You just basically took out all the vessels all in one. It was not until in the 2000s when reports of VATS lobectomy started coming out, which used the precise anatomic technique that people used to mirror open resections, came into play. You can see here that minimally invasive lobectomy involved no rib spreading. On the left in A was the large open lobectomy picture of a thoracotomy, and compared to B with the small incision. Next slide. So in comparing VATS versus open, I think you can press a button and press a button. On the left, we have complications. On the right, we have survival. So here we have the early reports. This is in 2013, comparing VATS versus open, showing that with VATS technique, we have less complications, and we also are able to demonstrate some improved survival long term. Next slide. In fact, when we look at more modern data from 2000 to 2009, 12,000 patients from our Society of Thoracic Surgeons database, we look at patients stratified by pulmonary function. So on the left of the graph, you have patients with poor pulmonary function with their FEV1 or PFT of 20 to 40. And towards the right of the graph, their FEV1 with good pulmonary function, 90 to 100. Patients who had VATS lobectomies and VATS operations were able to withstand and have less complications compared to patients with open thoracotomy incisions, particularly patients who had bad pulmonary function. So VATS was particularly helpful with patients who had bad pulmonary function. Next slide. And this was another paper in 2018, basically trying to answer the question, is minimally invasive lung cancer surgery the equivalent or as effective as patients undergoing thoracotomy? And this was linked to large databases between the Society of Thoracic Surgeons database and the US Medicare database. Basically 50% of patients with thoracotomy, 50% patients with VATS. The VATS patients were younger, more female, and had fewer comorbidity, but to adjust for that, they did a propensity analysis, and they did show that patients who underwent VATS operations had improved overall survival at 4 years. Next slide. So up to, there are about 5, before the modern era, there were about 5 randomized trials comparing VATS and thoracotomy. And the data was kind of equivalent until this past decade, because in the 1990s and 2000s, there was still a learning curve and technique. So we weren't sure whether it was better or not to have the VATS versus thoracotomy. Next slide. So this is the most recent trial, and it was actually just published in 2022, the results, called the Violet trial, which is a randomized trial based in the United Kingdom that randomized in a blinded fashion VATS versus open lobectomy for lung cancer. And the objective of this trial was to compare the clinical parameters and the costs between these two types of surgeries for stage 1 to 2 lung cancer. 500 patients were enrolled, and their primary outcome was how well did they physically function at 5 weeks, and their secondary outcomes was how efficacious, safe, how was the quality oncologically, and the costs. Next slide. So this was randomized and stratified by surgeon, therefore eliminating the surgeon-to-surgeon variability and allowing each surgeon to act as their own internal control. The patients and nurses were blinded to which procedure that the patient underwent, and postoperative pain assessment was performed using validated pain scores, morphine equivalents, and it also took into account regional and non-opioid analgesics. Next slide. So here you see as the primary outcome of the paper is that at 5 weeks, the patients who underwent VATS procedures in the red line had better physical functioning than patients who had open thoracotomy in the blue line. As you went out further out to 12 months, this difference went away. But so you had an earlier benefit in physical functioning with patients who had minimally invasive surgery. Next slide. Pain scores were also better among patients who had VATS lobectomy. So on the left in A, you see in the orange, on day 2 after the operation, patients with open lobectomy had more pain, required more pain medications than patients who had VATS. Interestingly, patients with prolonged incisional pain, so basically more than 30 days out, 60% of VATS patients still had incisional pain versus 72% of patients who had open surgery. Next slide. And VATS was safe. So here, this is a chart that shows any in-hospital adverse event or any in-hospital significant adverse event. And you can see that patients who were randomized to the VATS arm had significantly less in-hospital adverse events than patients who had open surgery. There was no difference in significant adverse events and no difference in readmissions. Next slide. And oncologically, the VATS procedure was as good as doing it open. So complete resection was the same, Getting the number of lymph nodes was the same, and sites of residual disease, whether it was at the bronchus or the vascular margin, was the same. Both arms received adjuvant therapy if they merited adjuvant therapy. So next slide. What the people in England found as well was that VATS ended up being cheaper than open lobectomy. So here you can see on the left, this column graph, that while initially in blue, VATS up front was more expensive because there's more technology being used in the operating room. After the procedure is over, there's less intensity of care needed, less length of stay in the hospital, less in-hospital complications, and less complications in that first year after operation, adding up to a total of cheaper care after VATS. Next. So in conclusion, this Violet trial, which is probably the best evidence we have to date to see the differences between VATS versus open lobectomy, we found that VATS lobectomy patients had less pain, significantly lower total complications, shorter length of stay, and did not compromise any oncologic outcomes, such as lymph node dissection, staging, complete resection, and also you had superior recovery continued after discharge because your physical function was better. When you leave the hospital with a better physical function, your trajectory for recovery is better, and your quality of life up to 1 year was better. There was no difference in long-term outcomes in recurrence, disease-free, or overall survival. And so therefore, the conclusion of this trial was VATS lobectomy is more effective and less costly compared to thoracotomy. Next slide. Moving on to the robot. So robot is a newer technology that is being applied in thoracic surgery very frequently now. In the 2000s, it was introduced and initially embraced by surgeons in urology and gynecology. And in 2010 was the first initial large series of robotic-assisted lobectomy. By 2017, because there was new technology, new staplers, a large amount of thoracic surgeons started using the robot for their lobectomy and any other lung resections. And right now it's dominated by one company called Da Vinci, but now there's new platforms by Google and Medtronic which are in development. Next slide. So this is what the robot looks like. You have a console, you have the robotic arms, and then on to the right you see that this is where the surgeon performs the operation farther from the patient. Next slide. So the advantage of robotic versus VATS is that the vision is 3D. So and the instruments that we use for the robot are wristed, so you have more flexibility of movement. And you can therefore use minimally invasive techniques, but with higher amount of technical ability and sharper dissection to do more complicated cases. Also, because it more closely mimics open techniques, it's easier for surgeons to learn. So you need less cases to become a master. Next slide. Here's some pictures of how it actually looks like in the operating room, where you have a surgeon who's standing. We have a surgeon who's doing the operation at the console on the left. And in the middle, you see some other surgeons who are assisting at the patient bedside to help insert instruments. And on the right, you have what is seen through the surgeon console viewpoint, that 3D vision that we can see to do complex dissections in the chest. The downside is that there is a large capital investment up front. The robot is expensive, and you have instruments and that you need to purchase. Next slide. You can see here that number of robotic procedures is increasing drastically from year to year. And I read a report recently that about 80% of lung resections in the state of Illinois are done by the robot as of 2023. Next slide. This is one of a few papers that have come out that compare the robot versus the VATS versus the open technique. And this is by Memorial Sloan Kettering. That's a retrospective review. Basically, minimally invasive surgery, whether it's robot or VATS, seem equivalent at this point in time. They both have advantages over the open technique. But the robot does seem to have a trend towards more lymph node stations being harvested. So more lymph nodes being that because the robot is so much better at dissecting in tight corners, you're able to get more lymph nodes out. However, there was no difference in your surgical an oncological outcome, meaning your overall survival or disease-free survival, if you had a minimally invasive, robotic, VATS, or open approach. Next slide. So that is a brief overview of minimally invasive thoracic surgery techniques. This is my contact information, my email. Thank you very much for listening, and I'm going to hand it over to Dr. Mohindra.
Thanks. This has been such a great overview. I even myself, I learned a lot. So my name is Nisha Mohindra. I am a medical oncologist, and we'll give you an update on the advances we've made in lung cancer treatment, both in the molecular setting as well as immunotherapy. Next slide. These are my disclosures. Next. So today, briefly, I'll give you a historical perspective because I think it helps set the stage for how much progress we've made, and certainly leaves optimism for how we think about the future. There are a couple of themes that I think have improved outcomes, and we'll briefly hit on what is precision oncology, what are things that we're doing to target things that have been felt to be untargetable. There's an excitement around antibody drug conjugates. We'll briefly talk about how those work, and then how are we bringing some of this excitement to early stage disease. Next slide. So it is 2023, and I know we have all come through 2 or more years of a change in our world, but I want to highlight that despite having a pandemic, there have been a number of approvals that have been set forth in lung cancer. So it did not slow progress, and we've certainly seen advances despite what's happened in the world. Next slide. So I think Dr. Desai has nicely highlighted the reality of lung cancer currently. It still remains the leading cause of cancer-related deaths in the US and the world, and the second most common new cause of diagnosis of cancer in both men and women. Next slide. I think this has been nicely highlighted, but a lot of what we see as medical oncologists are patients that have presented when disease is either locally advanced or metastatic. And certainly we've seen in prior presentations that the outcomes are more dismal when it's advanced stage disease. Next slide. So if we look just even 20 years ago in the early 2000s, the survival for lung cancer was about 8 months. And, we had a very one-size-fits-all approach to chemotherapy. A decade after that, we started realizing that there were molecular targets, so there were specific subsets, and we developed some targeted therapies, first of all with EGFR. We started to see improvements in survivals to over a year. And I think in the more current era between immunotherapy and targeted therapy, as well as earlier detection of disease, we're seeing survival closer to 2 years. Next slide. And I think that this has not been missed by the lay press. Certainly, scientific journals have noted the advancements, but I think it's nice to see that it's making headlines in other places as well. We're seeing sharp declines in cancer death rates, and I think that this is certainly noteworthy across the board. Next slide. So like I said, one of the major advances we've seen is that we don't treat the disease as one disease entity. I think 20 years ago when we gave chemotherapy, we saw it as one disease. We started to recognize that there were different cells in lung cancer, different histologic subsets, and we understood that chemo could be tailored based on that. But I think really where we've made the most advancement is in the fact that there are these molecular drivers, these mutations and other alterations that happen in these cancers that we can now target. And we're seeing that when we do that, we have improved outcomes. Next slide. So really the concept goes back to, if you look on the left, we would treat everybody with the same treatment. And we knew that some would benefit. However, there would be some that would not benefit, and we knew that we were giving side effects to most all. If we look on the right, where we're doing a more precision-based approach, we're saying, well, it shouldn't be the same treatment for all patients. We should really be using profiling and an understanding of disease biology, whether it's how the tumor interacts with the immune system or the underpinnings inside the cell. And if we can tailor that treatment specifically, we can hope to benefit more patients and spare patients toxicity without benefit. Next slide. Another major advancement has been that we are starting to understand how to better target some of our targets that have been felt to be untargetable. So KRAS has been a known oncogene for 30 years, and it is present in about 44% of lung cancers. There is a specific point mutation KRAS G12C that's present in about 13% of non-small cell lung cancers, and for decades there have been failed attempts at how do you target this subset of tumors. Next slide. And through some nice, elegant work, we started to understand disease biology in a way where you could match it with medicinal chemistry and really start to tailor how you treat. So if you think about KRAS, it's a protein inside the cell, and what it does is it cycles between active and inactive. When it's active, it's bound to GTP, and you don't need to be a cellular biologist to understand this. I'll make it easy. And when it's inactive, it's bound to GDP. What they realized was when it was in the inactive state, there was a little pocket where molecules could fit. And that's where drugs were developed that could keep that protein in the inactive state. And I think that that really led to some of our KRAS-directed therapies. Next slide. So we started to see that when we developed drugs that could do that and lock it in an inactive state, we were starting to make progress and see some responses in KRAS G12C, specifically in a population of patients where we had not had a targeted therapy yet. Certainly, we're still working in this subset to make these improvements even better, but I think this was a major advancement saying, hey, there are ways that we can target even things that have been historically untargetable. Next slide. So if we look at the decade of work, you can just see the number of both molecular subsets that have been identified, but also the number of treatments that are now available, not only in the first line, second line setting. And we've just seen such a plethora of drugs come to our clinics. Next slide. And so when we look at this, we see a nice table where we understand that we really shouldn't be treating everyone the same, and that we do now have very specific drugs, and in some cases, several classes of these drugs that we should be using with or before chemotherapy. Next slide. I think a lung cancer talk in today's age cannot be given without at least talking about the immune system. And I think that immunotherapy has certainly really also, for those without targeted molecular targets, has really improved survival in a way that I think we are still understanding what true survivorship looks like. So immune checkpoint proteins are proteins such as the programmed cell death ligand and CTLA4 that are normally expressed in tissue that help prevent attack by T cells. So it's stuff that the body knows what to do with. But tumors utilize these proteins to kind of escape the immune system. They too can upregulate these proteins and essentially escape immune attack. Next slide. So now we have a number of agents that can block that interaction between the immune system the tumor turning off the immune system and re-engage a patient's immune system in fighting their cancer. And really what I want to show is that we are seeing that there are long-term survivors. These are just kind of 5-year survival curves from some of these trials, and these are pooled data looking at response based on the response to treatment. But what I will say is we in lung cancer, to see a 5-year survival curve where we can see long-term survivors for stage 4 disease is really nice. So there are long-term survivors, and I think our definition of what survivorship looks like is now extending to patients who have historically had what we call non-curative stage 4 disease. Next slide. So this is the highlight, and there's no way to read this whole slide, but it's a lot of progress and it's hard to keep up with. But I think what this demonstrates is that we've made a lot of depth of understanding and how to treat and how to understand disease. And I think this momentum is carrying, and we're seeing an immense effort in clinical trials of really getting even deeper into how do you treat after you've used these targeted agents, and what else can you add to the immune system to really augment that response and keep the duration of control for even longer. So when I see a patient in clinic, it's important that I not only know the stage of disease and that it's lung cancer, but that I really understand the biology which drives that cancer. Histology is still very important. You know, what cell type did this originate from? But beyond that, it goes into what is driving that cell at a molecular level and what is that interaction with the immune system. And I would say that to create an optimal treatment strategy for lung cancer, it really has to encompass all of this information up front. And so getting tissue and really having enough of this data available helps us as medical oncologists really tailor these treatments for patients when we see them in clinic. Next slide. There has been a lot of talk about antibody drug conjugates, and I will not spend a lot of time on this, but I think these are coming into the scene, and patients and physicians are starting to hear about this. And these are just more unique and precise ways to possibly deliver cytotoxic chemotherapy. It's using antibodies that have been developed for proteins on the tumor surface so they can bind and attach. And then attached to these molecules are kind of chemotherapy agents that can be delivered inside this cell. So the next slide will actually kind of go through what this looks like. So again, these antibody drug conjugates have an antibody component, so they can attach to the cell on a specific protein that hopefully is mostly in the tumor and not in the normal human tissue. Once it attaches, it gets engrossed inside the cell, and inside the cell, the chemotherapy gets released. So you're delivering chemotherapy inside the cell as opposed to throughout the body. It also has that antibody component, and we know that when antibodies are present on certain cells, it creates an immune response. So we're getting kind of two ways of treating cancer. Next slide. So there are a number of targets that are being developed, and I think we'll hear more about these in the years to come, but these are being developed for not only non-small cell lung cancer, but also for small cell lung cancer. Next slide. So we have learned a lot in stage 4 disease, but certainly the important part is to bring this to earlier stages of disease. How do we help the surgeons who've done such a great job at curing lung cancer improve the survival for more patients? Next slide. So there's a lot of work on what can we do before surgery, what can we do after surgery, and should we be doing before and after? And I think this is a space that's emerging. There's also interest in how to use the targeted agents before and after surgery. So the treatment paradigm for resectable disease has become a lot more multidisciplinary. Next slide. Next slide. Oh, you can go back one slide. So the immune system can be activated both before and after surgery, like we've said. Before surgery, there's some advantages. The tumor is still there. The immune system can learn what it's trying to attack, and then hopefully those immune cells remember what the tumor looks like. So you get a rich activation of many T cells, and that's in the bottom slide. And in the top slide, you can do this after surgery. There still may be microscopic cells that are still present, and if you activate the immune system after surgery, they may continue to help prevent disease recurrence in the future. So again, two ways to activate the immune system, both before or after, or both before and after surgery. Next slide. So we first saw some exciting data when they used an immunotherapy before surgery and compared it to chemo. On the left, we saw that patients that got the combination of immunotherapy and chemo had more complete pathologic responses, meaning there was no detectable tumor at the time of surgery compared to chemo. We're seeing that the survival is also improved. So again, trying to use these novel agents that we've seen success with in stage 4 disease and moving them before a curative intent surgery. Next slide. And again, we're seeing data for this after surgery as well in the adjuvant setting. So there are ways to use these drugs, and we have early hints that at least in terms of disease-free survival, there is an advantage to considering this in the right patient population. Next slide. And we can't be remiss to say that there are only molecular subsets in stage 4 disease. We know those molecular subsets still exist in early stage disease. The proportions may be slightly different, but what can we use? How do we use this data now, again, for early stage disease? Next slide. The best example that we have so far is from the ADORA trial. This was a trial where patients with an EGFR mutation were given either osimertinib, which is an EGFR-directed tyrosine kinase inhibitor after surgery for 3 years, or they were given placebo. Next slide. And I think this year at ASCO, we saw some really nice results. We saw the 5-year survival data from this trial. And again, you can see easily that the survival curves separate, showing that using a targeted agent after surgery improved 5-year overall survival. Next slide. So I think we have made a lot of progress, and I know that the current state still says that lung cancer is the leading cause of death in the US, but you can see that we're making a lot of progress in terms of improving survival, and that's come from years of science and finally understanding how to use the information to our advantage, access to clinical trials, and then collaboration. I think patients and caregivers give us so much insight into how we can improve disease trajectories, but what is meaningful improvement in survival. And we have to do better. I think we have work to do. Just, addressing disparities, making sure that more patients can get on the right trials, have access to the care that will get them the improved outcomes. And I think it would be hard to say that, we're treating patients a lot more. We talk about bringing these drugs into the early stages of disease, and we're talking about treatment for some patients for 3 years after surgery. So how do we make this affordable and livable is a big thing that we really need to think about. So I think the whole panel has been talking about curing more individuals, getting to disease earlier, but there is a lot of optimism for the future. So with that, I will end. Thank you.
Thank you, Dr. Mohindra and Dr. Madriaga. I think those are fantastic presentations. Learned a lot. I think, and definitely what I can sense and feel is a lot of optimism. Yes, definitely a lot of work needs to be done, but there's a lot of hope and positivity around lung cancer. So thank you so much for sharing those valuable presentations. I'm going to open up to our audience to ask any questions to any of our panelists. We're here, to ask anything, answer anything that you have. As you guys are thinking about some questions to come up, and as Danielle mentioned, and you can type it in the chat box. I have a question, and it is more so, looking at how, in your respective institutions, right? If someone is diagnosed with lung cancer, how do you approach the care for patients, and how do you move forward? How do you decide what should go first? What should we do first? Maybe I think Dr. Madriaga or Dr. Mohindra, you can start.
Well, I think I think it's very important to work as a group. So that's why we have our multidisciplinary meetings, because as Dr. Mohindra pointed out, there's so much new medications out there that can help patients. So we need to have as much information as possible about the biology and the molecular makeup of the lung cancer. It's no longer just cut it out, where there's a lot much more refined therapies. And then side by side with that is basically figuring out what's best for the patient. So understanding their goals of what they want to accomplish, how they want to live their lives, and getting them up to snuff in order to be strong enough to go through whatever treatment pathway they want to go to.
Yeah, I mean, I agree. We too have created a multidisciplinary clinic where pulmonary, thoracic surgery, med-onc, palliative care all sit in the same workspace. Um, and I think that's helped because we can not only kind of cross bounce ideas with each other, but if patients need to be seen together, because a lot of times you're still getting some information worked up and we're trying to minimize delays to the ultimate goal of whatever we're getting to next. So we're trying to get the approach of a multidisciplinary clinic so we all can be involved at an early point.
And I think that is a great point that you both highlighted. I think getting to the not only the diagnosis but getting to the next step for treatment, especially after multidisciplinary collaboration, right? It can be very challenging to have so many people, and that's why tumor boards and multidisciplinary clinic like what you have, Dr. Mohindra, is very helpful. One question for Dr. Madhya, I think, oftentimes we see patients in the clinic, right? They get diagnosed with lung cancer and they're going to go through surgery. Obviously, we're doing better, but then some may actually, still be smoking. What is your advice for them?
Quit smoking. It's very, very hard to quit. I understand. It's super, super, super hard. But the data does show that patients who are smoking up to the time of surgery have worse outcomes in terms of complications, longer hospital stay, pneumonias, and even death. So we really do our best to encourage patients to stop smoking. Even decreasing the amount of smoking that the patient does is beneficial, and we give them time. So for example, we can delay surgery for a bit while patients are trying to quit. We offer them smoking cessation clinics, smoking cessation groups, all those kinds of things. At the end of the day, it is a surgeon-specific decision whether to offer surgery or not to a patient who is smoking. And so you have some surgeons who will never operate on a smoker, and some surgeons who will. So it's a surgeon's decision at the end of the day. But for the safety of the patient, I would highly recommend quit smoking.
So that's a great point. I think so. It's not only good for them long run, but it's also just in the short term when they're undergoing surgery, it improves outcomes. So that is very helpful. Dr. Mohinder, one of the other things that we face, right? I think, and you touched upon that. So I just want you to sort of maybe elaborate a little bit on that. Oftentimes when we see patients in the clinic, right? When they have stage 3, stage 4 disease, it's a difficult time, especially in the line of obviously the continuum of care, position where I am is usually oftentimes we diagnose them, but we're not the ones who are treating them. And oftentimes we are left with, how positive can you be? How do you approach these, questions? And obviously, is your approach the same what it used to be 5 years ago in telling patients, and so what do you tell your patients?
It's a good question, and it's come up a lot because I think we're all understanding what the true impact of some of our treatments can be. And I think we're historically always bad at prognosticating in general, but as these treatments get better, I think what I tell patients is that we have a lot more options than we've ever had. And I think we understand and can tailor disease treatments much more sophisticatedly than we have in the past, and that we should continue to look at the disease over time. I think there's a lot of interest in oligometastatic disease, things that you can still try to cure in different ways that haven't been the traditional, in the box thinking. So, um, it's hard because you always say, how do you maintain the optimism? But I think there is much more to offer, and there's a lot of ways to approach disease that we haven't explored the same way we did 10 years ago. We really try to think outside the box of, at some point, is there a way to think about being a little bit more aggressive with, even in the stage 4 setting, with with resection or radiation? Um, I think the time from biopsy to starting treatment is the hardest time for most of my patients. Waiting to know what the final destination is. They are like, it's easier to start chemo than to be waiting in that limbo of what's my stage and what's going to happen next. So I think you get them at a very high stress time, as do we, but it does get better once you have a treatment plan in place. So I think just getting them to the right people fast is what's probably gonna be the most helpful.
I think let's see if we have any questions. I think Mary just commented, thank you all, great webinar. So I don't see any more questions. Really, I think fantastic presentations. Thank you so much, Dr. Madriaga and Dr. Mohindra, and also Michaela for the amazing presentations. It's always so exciting to see the advances in lung cancer care. On behalf of American Lung Association, I would like to thank you all, attendees, as well as our phenomenal speakers again, for joining this evening. American Lung Association does some amazing work, and one of them is Fight for Air climbs. I have been climbing with my family for the past, I would say, 8 years. It's awesome. Me, my wife, my 2 kids, we all join, and now my little daughter, she's 8 years, and she climbed with me last year as well, so which is awesome. Get involved. It's a great event. You can have family there. It obviously helps increase awareness for lung health. And Danielle also mentioned the website that we can go to. Obviously cannot do this without our amazing ALA team. So I would like to thank Danielle, Olivia, for their support, and thank you for everything that you do for us here in Chicago. Thank you.
Thank you.
Thank you all.
Thank you.